Hey guys, welcome back to my channel. Opeyemi here. You're welcome to Opeyemi's Corner. And on this channel, I make videos on medicine and lifestyle, just basically to encourage doctors, medical students, and also to entertain you guys. And in today's video, I'm going to be doing a video I wish I saw before coming into the UK. So I remember when I got my job, one of the first things I did was, go on YouTube to kind of get an insight into what the job entailed. And was hoping I would see like vlogs because like some doctors do content in hospital and make vlogs and all that stuff, but I never really saw any. And I get it because obviously you need to be careful with filming in the hospital, plus working in A&E doesn't even give you that luxury to really do much content around the hospital. But I just thought I would do like a sit down video just to kind of give an idea of what working in A&E entails. And please bear in mind that it varies for different trusts. So the things that might be happening in my trust might be different from what would happen in the trust where you work or where you're about to start working or anything like that. But this is just to have like a general overview. So I've got my phone here and I've just written down a few things so I don't forget. And yeah, we'll just dive right into the video. And I hope that at the end of this video, you kind of get how things work and you're a bit more prepared if you have to like an A&E posting or if you have to work in A&E, right? So as you know, A&E, is also called ED. Majorly, these are like two names that people use. So that accident and emergency or emergency department. So like I said, the structure varies in different hospitals, but generally this gives you an idea. So in the A&E, we work in shift patterns, and in my trust, we have 4 different types. So we have morning shifts, we have mid, we have late, and we have night shifts. So I'll tell you guys the times we do. So we do 8 to 6 p.m. That's the morning shift. And all our shifts are 10 hours minimum. The usual is 10 hours. There are some exceptions, which I will talk about. I know some trusts do like a variation. Some do 8, some have 8-hour shifts, some have 9-hour shifts, and some have 10-hour shifts. But my trust, we do, 10 as the baseline. So we've got 8 to 6, which is our morning shift. We've got 12 to 10 p.m., which is our midday shift. We've got 2 p.m. to midnight, which is our late shift. And we've got 10 p.m. to 8 a.m., well, spans to 8:30 because of handover in the morning, which is our night shift. So those are the 4 major shifts we have. But on the weekends, our 8 to morning shift is usually 12 hours. So if you're working a morning shift over the weekend or working a night shift over the weekend, it will be 12 hours. So that will be 8 a.m. to 8 p.m. and then 8 p.m. to 8 a.m. the next day. But that doesn't happen often. I think we do that once every 4 months or something like that. So it doesn't come around often like that. And for me personally, I like the way things work in my trust because for doctors, we do 40 hours a week, except you're doing like a lower percentage. So working 10 hours means that most times we do like maximum of 40 hours, like we do 4 days and then can have the rest days off. And there are also ways that they do the rota whereby we then get more off days. So it just works for me really. And I feel like if I can do 8 hours, I can push and do 10 anyways. So those are the times we have. So some trusts use this as well, while some may have like 9 to 5 or would have like 11 to 7 rather than the 12 to 10. So it varies for different trusts, like I've mentioned, but this is just like an overview for you to note that you would work in variations of different shift times if you're working in the A&E. Then in terms of like people you would work with, again, I think it varies, but I think on an average, usually you would have like the healthcare assistant, the nurses, the junior doctors, the middle grades, and the consultants. But in my own trust, we also have the ACPs, which are the advanced clinical practitioners who also see patients and work in the A&E. So that's kind of like the team that you have that you work with. And then I'll just go next into in terms of like, for my trust, what areas do we have? So I know that when we hear A&E, sometimes you think, oh, it's just like the way it happens in, for example, Grey's Anatomy or Chicago Med, but it's not always like that. Many a times we also have cold cases, and cold cases are basically cases where you see and you can send them home, like where it's not an emergency, basically. So it's usually like a mix of that. And so we have a system in the hospital called like a pre-alert system where like the paramedics call in and alert the hospital about the cases they are bringing in that are serious, like if the patient is like really, really ill, or if it's like, a life or death situation, basically like really ill patients, they would pre-alert such a patient. And so what happens is that patients like that obviously will get priority and we would skip the line. Somebody would get assigned to see that patient on time, depending on, if the patient is going into. So while I'm just talking on that point, I will just go into the next point, which is the fact that we have different rooms. So we have something called resus, which is short for resuscitation. So the really ill patients, like really, really ill, go into resus. The ones who need like urgent life, urgent care, they go into resus. Then we also have something called monitoring in my trust. So monitoring is for those who are really ill but not ill enough to be in resource. So most times pre-alert either would get put in resource or would get put in monitoring. And for resource, usually there's no doctor that mans it like permanently. Usually what they would do is if there's a patient coming in for resource, they'll just pull someone and say, oh, can someone see that patient in resource? And most times they pull like the middle grade doctors, which are like the regs. But for monitoring, every 4 hours, there's usually a junior doctor in charge for monitoring. But the shift for monitoring usually ends at 12 midnight. And then over the night shifts, people kind of just peak. So we've got resource monitoring. And for the junior doctor, they always have like a middle grade or a consultant come around every now and then to kind of like see what's going on. And if you're stuck, you can always call for help. So the really ill ones go to resource or monitoring. And yeah, so if they go to resource, someone gets pulled to just see them. If they go to monitoring, there's somebody stationed there who sees them. And we also have like treatment rooms. So treatment rooms are like, okay, people that are ill and you still want an eye being kept on them. They're not ill enough to be in monitoring, but you think they need an eye to be kept on them. So they stay in the treatment rooms. And we've also got something called the ambulance handover. So when the ambulance, the paramedics bring people into the hospital, they go through ambulance handover rooms. And there's usually a nurse stationed there in a particular part of ambulance handover, because we have like two sections of ambulance handover, and the nurse would kind of like assess, is this patient, did the patient come in ambulance, but are they still stable enough to sit in the waiting room? Are they like really, really ill? Do we need to move them to monitoring even if they're not pre-alerted? What's going on with them? And so we have some patients there in ambulance handover. And then we have something called LA, which is the lower acuity ward, which kind of like, oh, this patient needs to come into hospital, but they're not very ill. They don't need to be in treatment room or they don't need to be in monitoring, but they're still going to be in A&E anyways, so they can stay in lower acuity. So for example, maybe like a chest infection, but they've got new oxygen requirements and they need antibiotics, and they're not, they don't have like a high news score where you need to keep an eye out for them every time. You can put them in lower acuity. And bear in mind that every of these areas are still manned by, multiple nurses. So it's not like, oh, they're out of anybody's care or anything like that. No, it's just how we strategically put patients in these different areas based on what they need. So I've kind of talked about the shift pattern we work, the time we do, how we kind of divide things, and how, there's priority for the ones that are really, really ill. And so usually for the cold cases, many a times they would be in the waiting room, and then we have rooms where we just kind of see. And even if they are in the waiting room, sometimes, they might need to come into hospital. So if they need to come into hospital, then you try to get them in bed. And if not, then you can discharge them home. Yeah, so I hope that kind of explains things to an extent. Then in terms of like, in terms of discussion, in my A&E, which I also believe applies to the majority of the A&Es, for doctors, we've got three categories of doctors. We have junior doctors, we have middle grade doctors, and we have consultants. So middle grades mostly are the ones who are in specialty training and have crossed. So for like ED, middle grades are ST3 and above. And yeah, and also for like SAS doctors or specialty doctors, they're also middle grades. I have a video on the doctor titles, so please don't be confused. Just watch that video for clarity. So usually what we do is when junior doctors see a patient, even if it's a cold case, I still make sure I discuss, just even if I've done all the right things, just to get someone to say, oh yeah, that's fine, they can go home. Or sometimes you realize that there are some things that you didn't pick up and you discuss with somebody more senior and they pick it up. Because with A&E, it's very fast paced, and you want to see as many patients as possible, but you also need to be very careful that you're not sending the wrong patient home. So that's the brilliant thing about discussion. And the way the department works, it works in such a way that the consultants are usually there on the shop floor, the regs are always there on the shop floor, and you can literally just go to one person and be like, oh, I've just seen this patient, I just wanted to run it by you, or I've just seen this patient and I have so and so concerns, I've just seen this patient and I think I'm not very comfortable with something, or I just need your input. If you did an X-ray, you can just make them, oh, can you please look through this X-ray for me? I've looked through, I didn't see any fracture. And there'll be times where you might miss a fracture, and a senior colleague would pick that fracture because obviously they have more experience, they have worked longer in A&E. So it's very great because we have that easy access to them to discuss patients. And usually during the day, there's usually a consultant from 8 a.m. to 10 p.m. There's always a consultant. So we have like a consultant who works 8 a.m. to 4 p.m. And then the on-call consultant starts at 4 p.m. to 10. And then even during the day as well, we have another like 11 to 7 shifts where there will be like a shop floor second consultant. Sometimes we have consultants also coming for rapid assessments called RAT. So there's always like a senior colleague to discuss with, really, to run things by. So don't feel scared and think, oh, what if I make wrong decisions, blah, blah, blah. You get someone to discuss with. And the good thing as well is that you've got internet, we've got trust policies. So if you're not sure about something, you can always go on the trust policy. Like, oh, for example, this patient has a clavicular fracture. What should be done? What's the ideal thing that should be done? There's a VFC, document. VFC means Virtual Fracture Clinic, and it just tells you what you need to do. There are antibiotics guidelines. There's literally a guideline for everything. Chest pain, anything at all, there's a guideline. And also, if you're not sure, even if you've seen the patient yourself and you're not comfortable, maybe you think that, I've seen the patient, maybe they have a wound and I'm not sure what's the next best thing to do, or, I need to suture and I'm not very comfortable doing that. Of course, you need to build your experience, but at least if you're new and, you're not sure and you're not comfortable, you can always go to someone and say, oh, I've got this man who's got this wound. I don't know what to do about it. I feel like, staples can work, but I'm not very confident about that. They're happy to come around, have a look and offer advice. And if you, maybe for example, you're having to do staples for the first time and you don't know how to, remember the first time I had to do staples, I met one of the regs and it was the one who showed me, and now I don't need to get someone to show me how to do staples again because I now know how to do it. So yeah, there's people around to always talk to and to always revert to. Yeah, so that, I hope this kind of gives some more insight. And in terms of like areas we cover, so usually when we resume work, like I mentioned, there's something called monitoring and a junior colleague gets put there. So the first thing is just kind of go on the board and see, am I monitoring or not? And then also on the rota, there's some times where we are put aside as well to see like pediatrics emergency. So I think every 4 months you have 5 days of pediatrics emergency. And yeah, so if you are booked on for pediatrics, so you just know that you're going to be seeing only peds cases that day. And most times we mostly see like the trauma cases because the pediatricians are, they are happier with A&E doctors seeing trauma than they seeing trauma. So basically that tells you. So I know for some trusts, when they come in the morning, they kind of divide people and say, oh, go here, go there. But for my own trust, the major division we do is for like peds and for monitoring. Generally, you can just pick people up in timely order. We also have something called see and treat, which is like for minor injuries. We've got people who man see and treat as well, some of the ACPs. So they kind of just crack on with see and treat. So doctors and other people don't necessarily, like, there are people who work specifically in see and treat. So if you're going down the list, you don't have to pick see and treat as long as there's still somebody there covering see and treat at that, that time. So yeah, that's how things basically work. So I was saying that I know that some trusts, they kind of say, oh, these people, you're going to work in ambulance handover throughout the day, or oh, you're going to work in treatment rooms throughout the day, or you're going to work in LA throughout the day. We don't really do that where I work. We kind of just go down the list. The specifics we do are peds, monitoring, see and treat. Every other one, we basically just pick the patients in time order as they come in. Yeah, so I think I'm basically covered. I hope this gives you a bit more of an insight as to how things work. So we have something called like the shop floor where everybody is, where there are computers. And like I said, that's where the consultants are. You go, you discuss. And yeah, it can be a bit intimidating when you first start because unlike on the ward, you work as a team. When in A&E, you're literally seeing your patient alone. You're literally coming up with a diagnosis in your head alone. Because even if you're going to discuss, you don't want to go and discuss and somebody's just telling, like, you don't want to go and discuss and sound like you don't know what you're doing. I think the best thing is to go and discuss when you've already done certain things. Like, for example, a patient comes with collapse. It just makes sense to make sure that the patient has already had an ECG, you've already seen the blood, you've already done a lying standing blood pressure. And if you're going to discuss such a patient and say, oh, I think this patient can go home, you're going to discuss with the understanding that you're going to discuss bearing in mind that you've done the things that you were expected to do, because it's not fair on your consultant to now let them start counting some things that you should do yourself. Although sometimes it might be a bit like, should I do a CT head or no? You can, have those conversations and all. But yeah, that's how things basically work in A&E. It can be isolating, like I said, because you're doing your things yourself. But as you make friends and as you start to talk to people more while you're like on your system doing your notes, you can have a conversation here and there, have a laugh here and there, and basically just enjoy it. So I like A&E. It can be a bit demanding sometimes, and with the shift patterns as well, it can be a bit difficult to kind of get some structure into many things in your life. But I think with time you just kind of get used to it, and like I like it because you get like many off days, and especially again like I mentioned, because we do 10 hours, we have more off days, and you get like off days during the week. Like today is a Saturday, fine, but there are days of the week where like Monday I'm off work, like Tuesday, Wednesday I'm off work, and I really don't mind it at all, because sometimes you just want to be able to do things during the week, right? So yeah, like I said, some things can be frustrating, like the systemic things, because sometimes there's no bed space, and it's not because of anybody's fault. It's just that, like we all know, the NHS is under a lot of pressure. So yeah, that's how things work in A&E. I hope this video has given you some insight. And yeah, thank you guys so much for watching. Thank you guys so much for watching. If you do have any more questions that you'd like me to answer or make clarifications about, ask away in the comment section. I'll be happy to answer your questions. Thank you so much for watching, and see you in my next video. Bye.